remove the maternal RBC from the baby's blood so that further hemolysis does not take place. Okay, that is why exchange transfusion is very important in addition to phototherapy. Assessment and monitoring of the fetal anemia previously required invasive tests such as chordocentesis of the fetal blood sampling and amniocentesis for optical density of the bilirubin in the amniotic fluid. Sometimes these are done. Her temperature 38.5, heart rate 120 per minute, blood pressure 91/63. Good afternoon, dear students. Welcome to our today's class. So today we are going to complete the rest of the part of the book 50 clinical cases of Mrcpch for AKP. In the last class we have completed the 25 cases and today we will be starting from the number 26. So the first case, a 5-year-old girl with wrist pain. The questions will be like this in the exam. There will be a clinical scenario and there will be some investigation reports. Okay. So 5-year-old girl seen in a general pediatric clinic with a 6 weeks history of episodic pain and stiffness affecting her wrist, ankle, right knee. Just by reading the first line, you can have an idea what is the case about. More than 6 weeks history of joint pain and involving more than 2 or 3 joints. In her detailed history, she had a swollen and painful right knee a year ago that was thought to be the result of trauma, and this settled down quickly after analgesia and rest. Since then, she has suffered with pain, swelling in different joints. There are no other symptoms. Her father was professional footballer who had surgery to his knee, and mother had eczema. These are irrelevant information. In AKP, they will give you lots of information, lots of family history and everything, just to make you a bit confused. On examination, she looks well but is slightly pale, temperature 37.6, no obvious dermatological abnormality, so psoriatic arthritis excluded. Examination of her joints shows obvious swelling without erythema of the right knee and left wrist. It means septic arthritis, osteomyelitis excluded. There is a limitation of movement of neck flexion, wrist, right knee, left ankle. Her spine demonstrates the limitation of flexion. The rest of the examination is normal. For the investigation, you see hemoglobin 98. In our term is around 9.8. MCV, MCH, MCHC a bit on the lower range. WBC count 14, ESR high, platelet count okay. CRP 20, rheumatoid factor negative, anti-nucleic antibody negative. The likely diagnosis is polyarticular juvenile idiopathic arthritis. Which one is the most next important investigation? Slit lamp examination. Slit lamp examination for the eye to see whether there is any uveitis present or not. Uveitis is somehow mostly asymptomatic. That is a very life-threatening, like a very damaging condition that a person can have, because after juvenile idiopathic arthritis there can be painless or asymptomatic uveitis that may lead to a person go completely blind. Okay, the young girl presents with 5 swollen joints developing over a 6-week period. That is why it is polyarticular juvenile idiopathic arthritis. Okay, she has limitation of movement in multiple joints. The absence of obvious dermatological findings makes Lyme disease, SLE and systemic GIA unlikely. A microcytic hypochromic anemia, raised ESR support the diagnosis of polyarticular juvenile arthritis. Uveitis in GIA is the most common, often asymptomatic and needs regular screening under a slit lamp. GIA is essentially a clinical diagnosis and one of the exclusion of the wide range of differential diagnosis. It is the most common chronic rheumatological disease in children. Okay, so this chapter is completely related to juvenile idiopathic arthritis. Okay, in this paragraph you see the pathogenesis and etiology of GIA are unclear, although interaction between genetic factor, immune mechanism and environmental exposure are all thought to be contribute. T lymphocytes have a central role in the inflammatory response and they release pro-inflammatory cytokines such as tumor necrotic factor alpha, interleukin 1, interleukin 6. The chronic inflammation of synovium is characterized by B lymphocytic infiltration and expansion. Rheumatoid factor assay detect immunoglobulin A antibody direct against the Fc protein of IgG molecule, whereas anti-nuclear antibody usually target specific antigen in the cell nuclei. So this paragraph is about pathogenicity. Usually in AKP pathogenesis related questions are less likely coming, and polyarticular GIA, oligoarticular GIA, the most important thing is whenever there is anti-nucleic antibody positive, it is very likely that this child will get uveitis and prognosis will be a bit slower rather than being positive with Rh factor. Okay, so if you are ANA positive, that will make you more prone to uveitis. Okay, now come to the next page, second paragraph, psoriatic arthritis. Usually psoriatic arthritis are asymmetrical, may involve the finger joints, and mostly there should be a psoriasis and positive family history. Positive family history of psoriasis. Psoriasis like lesion along with the arthritis, and there should be positive family history of psoriasis. In this case, we can say mother had eczema, not psoriasis. Am I clear why they have written that clue? Just to give you a clue. Enthesitis-related arthritis describes an inflammatory process at the site of muscle insertion, leading to pain and erythema. Lower limb joints are usually affected, particularly the ankle. The young person is at risk of uveitis and inflammatory bowel disease. Investigation may identify a personal or family history of HLA-B27 positivity. This was one of the questions from my test or AKP. I believe which one of the following arthritis is HLA-B27 related to HLA-B27. That was enthesitis related arthritis. Then psoriatic arthritis is also related to HLA-B27. Okay. The goal of management. You see, the medical management will involve the use of NSAIDs like ibuprofen. Therefore, the approach is to arrest the inflammatory process with corticosteroid. It can be intra-articular, it can be systemic. To maintain the position, the disease-modifying anti-rheumatic drugs are also important. Oral and subcutaneous methotrexate given each week is used in this way. An adequate response to methotrexate requires an escalation to biological cytokine modulator like etanercept, infliximab and adalimumab, okay, which inhibits the effect of tumor necrotic factor. Okay, many of the agents are also used for the treatment of uveitis. Surgical interventions such as joint replacement, synovectomy are rarely required now due to advance in medical segment. The long-term outlook for children and young people who are diagnosed with JIA is very good, as the disease is often self-limiting. About 60% of the patient can be expected to reach adulthood with no active synovitis or functional limitation. Okay, let's go to the next case. A newborn baby with generalized edema. A male infant born at 34 weeks of gestation is noted to be edematous and pale with poor respiratory effort, shallow breathing soon after birth. Birth weight 2.9 kg, admitted to the NICU and on nasal CPAP for 5 cm, water with supplemental oxygen. Further examination reveals a heart rate of 170 per minute, respiratory rate 60 per minute and a slightly distended abdomen with generalized edema. His mother moved to UK recently and a late antenatal booking blood test confirmed her blood group was Rh negative, that means O negative. She had a 3-year-old daughter who was born 39 weeks of gestation in Egypt and was treated with phototherapy for jaundice. A chest X-ray was taken at about 4 hours of age, shows the features of poor aeration and obliteration of the costophrenic angle of the both sides. So which one of the following investigation should give the most definitive confirmation the baby has got autoimmune hemolytic disease? Direct Coombs test, another name is direct antiglobulin test. In case of first baby, usually this sort of Rh incompatibility does not affect much. But in case of the second baby and further pregnancy, this Rh incompatibility affects more. That is why we give anti-D injection to the mother, right? So what is the definitive test to do? That is direct Coombs test or direct antiglobulin test. The infant's initial blood test on the admission are repeated at 4 hours of age and shows hemoglobin 87. That is a very low hemoglobin for a newborn. Okay, total bilirubin is 100 and direct antiglobulin test positive and blood group is O positive. That is why directly the antigen antibody reaction is occurring. Mother is O negative and the baby is O positive. Intensive phototherapy treatment has been started. What is the most important management indicated in addition to phototherapy? Definitely exchange transfusion, because the hemoglobin is very low, continuous hemolysis is ongoing. So at that point you have to give exchange transfusion to remove the maternal RBC from the baby's blood so that further hemolysis does not take place. Okay, that is why exchange transfusion is very important in addition to phototherapy. Okay.